Okay, so we used to get about 2 patients in a month. Now we get about 18 in a week, 15 to 18 patients we get in a week. Why? Because one, it's a referral center. And second, most of the private setups don't have the capability of GA, and they don't want to follow the patient. These patients actually will stick with you for next at least 30, 40 years. And that's why if you do it properly, do it. If you don't know how to do it, please pass it on to somebody who can manage it well. So it's basically institution-based. You need a good, safe anesthesia. But if you see the epidemiology, it is about 1 to 15 in 10,000. So the unit they take is 10,000 live births. How many are there is how they calculate. So different parts of the world have different setups. But if you see, okay, so when the parents bring the children and you tell them you got a cataract, the first thing is cataract in a small child? Are you nuts? Is it not a senile thing? The answer is no, and its number is rising up. Parents are to be taught about it because the child can't understand anything, and all these things about glasses, compliance. I mean, you just can't do a surgery in a patient in which they're not going to wear the glasses because we're undercorrecting this patient, so they might have a mild to moderate hyperopia left, for which the glasses have to be worn till they outgrow those glasses. They'll need the glasses forever, actually, after that. You're putting bifocal glasses for them, and eventually, if you can put a multifocal lenses later on when the child's growth stops, you can do them, but till that time, you have to make sure that the patient wear the glasses and have vision rather than going blind. Unilateral cases needs patching, but then again, parents have to be taught properly how to handle this properly. If they don't do the patching, I think everything's going to fall flat. All the siblings have to be evaluated. So in my setup, in RP center, if the parent comes with the child, we dilate the parent's eyes also. Both the mother, father will come. We don't want the uncles and nephews and neighbors to bring the child. We want the parents, actual, real, biological parents. And you put 1 drop of tropamide and just do a distant direct. You can actually see. So many times we picked up mother having as a carrier, and it becomes a Hansen-Noran syndrome. So, but you have to look for it, right? And this is not a one-window surgery like an adult cataract or a LASIK surgery. Patient pays and gets surgery, goes, never comes back. Here the case starts after the surgery. So once you've done a surgery, follow-up has to be done, suture removal has to be done. So every time the patient comes, you have to give it a diligent examination on this one. So basically the cataract forms very early in life without even the female realizing that she's pregnant. The lens starts forming. So that's a placard. I'm not going into the details of the genetics, but by 45 days, the lens is almost ready. So if you see the spectrum, everywhere there's the rise in USA, earlier they thought they were less patient, but now with the migratory population there, their number is also whooping going up. So they all are looking for pediatric cataract surgeons. So if you're ready for it, I think I'll wish you all the best. We did a study at the center in which we took the data of about 2,000 patients coming to our center. We realized that the majority of them were actually developmental cataracts, about 45%. Traumatic was very high. We're not dealing with the traumatic today because we're talking about the non-traumatic cataracts only today. And the last group here, 6% is the one visual excess opacification. That means if you haven't done the surgery properly, you might still have complication. You might need a resurgery. So you've got to be careful about that. So with that in mind, if one child is blind, there has to be a relative who handles the child. So there are 2 people who are not working for the GDP of the country. So they're basically not helping the economical cause. So you have to operate. A stitch in time will save 9 is very apt for this one. With this one, if the patient comes to us, how will you go and do a preoperative workup? Over to Arush.